you. All right, it is the top of the hour at my end, so we'll go ahead and get started. We have a full meeting for everyone. So good afternoon. My name is Gabriela Gonzalez. I'm with the EMI team, and we warmly welcome you to our third meeting. Today, we'll be covering story and use case development process kickoff and share the business case voting results with the group. As housekeeping items, we just wanted to share that you will have Zoom features available for interaction. We welcome your messages via the chat box. If you do send a message, please make sure that it's addressed to everyone so we can see the messages. We're very open to live feedback. We want to hear from you. Today's session is going to be more interactive. We have allocated time to really hear from you. So we encourage you to use the reaction button. There's a raise hand feature, and we'll be able to unmute you so you can ask or share your feedback live. As a friendly reminder, today's session is being recorded and all materials will be available via our Confluence site. So we do see a little bit more of traffic there in terms of worker members joining the call, so we welcome you. Please feel free to say hello via the chat, and if you can, please add your organization name onto your name so we're able to see who we have in the room. Here is today's agenda. We want to welcome you, really provide, today's meeting is centered around the story and the use case development process. And then majority of the call today, we're going to present to you some persona candidates as well as a story and have a dialogue. We want that to be a bi-directional feedback, component. So please really encourage you, if you can, raise your hand so we can hear from you live. Then we'll kind of wrap up with some housekeeping items, give you an overview of the business case consensus voting results and the summary of the comments received, as well as workgroup Confluence navigation and highlight some next steps and homework. If anyone on the call is new, if you have not done so, please, we currently invite you to officially join the work group as a member. If you're not sure your membership status, there is a feature that you can see whether you are a committed member or a other interested party. If for any reason you would like to adjust your membership status, you can contact me directly and we'll be happy to do the adjustments offline. You do not need to register again. We do clean up and scrub the listserv weekly in order to update our listserv email, which is our other admin update. We have created a HL7 listserv. So this really houses everyone on the work group that has signed up. In case that you may miss the emails, or if they're getting to your spam, we recommend whitelisting this email address. As you can see here, you can add it to your contacts so it can be filtered out of spam, or if you're not sure, we recommend contacting your health information personnel for support. And if there's any questions regarding the work group, if you need more assistance, do not hesitate to contact myself, Savannah, and or our CDC lead, Kyla Davis, who's also on the line. This slide might be familiar. We are bringing it forward on every session to ground our schedule and work group meeting layout. So right now we are on May 18, as you can see here. And we will have a total of 8 sessions, culminating in July 27. Kind of honing in on today's objective. Our purpose for everyone today is to introduce the development process of a use case package, which is our workgroup deliverable. We are going to present and discuss initial personas and the story, and then we'll review our consensus voting results. So it was a team effort, and sneak peek, we did reach consensus, so we will be sharing those results with all of you today. As a general reminder, we want you to be mindful of some of the elements that are out of scope. So this is a reference slide And if this is your first time joining our workgroup call, we kindly ask you to please become familiar with the workgroup charter. We'll put the link in the chat. It really states our timeline, what's in scope, what's out of scope, who are our partners. So it's really a guiding document if you're joining for the first time. And if you have any questions, do not hesitate to reach out to us. Thank you, Savannah, for dropping in the link. All right, so right on time, we'll hand over the virtual mic to Evelyn.
Thank you. Good afternoon, everyone. Thank you for joining us today. I'm Evelyn Gallego, and I'll go through the use case development process. If we can move on to the next slide. Okay, so just a reminder, won't spend too much time here. This is introduced in our charter and as part of our initial slides describing what we mean by a use case. So quickly, it is a framework to guide the development of a solution needed to meet the business drivers or business need. We just voted on the business case. So this is really the next phase of it. And the objective is to define the functional requirements and technical specifications of a solution by describing the interactions. And so as we go through, and today we won't do a deep dive on the use cases themselves because we're starting with the components. And lastly, the last bullet is why we want to do a use case and build a use case, because we use it as a tool to communicate what a solution needs to do without actually knowing how the solution will be built. So this is important for our community today, because often we say, you know, what is the use case? What do you mean by that workflow? What is going to come out of it? And really the purpose is here is just to define what those transactions need to be, the what that needs to happen, and the how is part of implementation. Next slide. So the use case, in addition to the use cases themselves, as we define as the narratives of the interactions between personas and systems, we also have, we define them starting with personas, which you will learn about today. And these are the who. These are fictional characters who represent a person expected to use a service or product, also referred to as a human actors within a use case. Amy will go through deeper dive on what we mean by personas. The use case also includes a story. We're not talking about a patient story here because this is a public health initiative, but we need a story to really describe how these various personas engage with the service, technology, or setting over a period of time to accomplish a goal. And then this brings us to the use cases. So we can't get to a use case without having the personas or the actors and the story clearly defined. Next slide. So the use case package we will work on together consists of these following sections. And as we go through in the coming weeks, we'll go through each of these one by one. So I won't go through, but it has overall 7 sections with appendices. Each one of them will have descriptors. Again, this very much follows what we completed for those following the Gravity project. We had a use case package as well, had this similar approach because the SDOH public health use case is following the Gravity framework. So we're using the same outline, but again, catering it to this specific. So if we move on to the next slide, it really talks through on our expectations for you all. So our approach is really, the project team will develop this use case package, put all the sections together, but it is very important on your feedback. So you see feedback highlighted on the slide because we really want to hear from you live. The purpose of these meetings, as Gabby alluded to, really use the chat feature. We have pauses where we really want you to comment on what we're presenting, right? This is really an important or critical part of our process. So as we go through and develop this use case package, we need to hear from you every step of the way on what we're doing, right? So we need feedback, live feedback. So it's not, again, you will have homework, but it's really, I cannot emphasize how important it is for you to share your feedback live as part of these meetings. So we need to hear from you on these draft personas, the story we'll present, and the use cases. We'll need feedback on the actors and roles that we'll define based on those use cases. We need feedback on the assumptions, preconditions, and post-conditions. And for those not familiar with use cases, these really are the sections that will lay the foundation for creating the functional and data set requirements. We will have lots of assumptions. We also will need to have dependencies, like these things that need to happen or be in place, what we refer to as precondition. And when we get to that, we'll define that further. And then what are things that need to happen after the activity, the post conditions. We will have draft diagrams. We'll need your feedback on those. And these diagrams will show a visual of the different interactions. Again, if you want to see examples of these, please see the ones from the Gravity use case package, so you'll understand what we mean by those visuals. If not, you'll wait till we get to this in our meetings. Next slide. Okay, so we'll also need feedback on these draft functional requirements, really important for our work. This is where you'll have the ability to identify capabilities a system must have in order to support the interoperable collection, analysis, and exchange of SDOH data for public health purposes. And so this section, when we get to it, will provide a detailed breakdown of the requirements in terms of intended functional behaviors of an application. Then we need your feedback on issues, risks, and obstacles, also really important to document. So throughout our process, we will identify, we also want to hear from you, often I've heard in other use case development, that's not possible. That doesn't happen in real life, right? That will never happen. This is where you bring it up, where you'll say, we really have a gap because we don't really have a system or a policy or our data infrastructure will not support that type of data collection and exchange. So please do so. And then at the end, you get to vote on it just like you did on the business case. Next slide. Okay, so with that, I'm happy to hand over to Amy to do a deeper dive on the personas and story.
Great, good afternoon, everyone. So as Evelyn said, I'm going to be doing talking through the personas and the story. So, and then there will be opportunity for discussion. I will get through the personas first, then we'll have some discussions about them and then the story as well. So next slide, please. So as Evelyn started to say, personas are really fictional representations of users, and the personas really, they're meant to highlight the goals and behaviors and motivations of real users. It's not a stereotype, it's more of an archetype, which really is an example of a certain type of person. They can be used to share insights across the team, and so that you all can sort of try to understand from a user perspective who these characters or personas would be. They are fictional, but they're often based on common user needs and patterns. Next slide, please. So for each of the personas that we've created, and we've created 4, we have a name, an age, family status, education, who their employer is or where they work. And then we talk about some preferences, challenges, and goals. And we've put these in really in the context of their professional setting, since that's the use cases will be focused on, their roles in their professional roles. Next slide. So before I go any further, both for the personas and when I go through the story, we just wanted to lay out some questions that we want you to be thinking about, because these are the questions we're going to come back and ask you for feedback and input on. So the questions that we'll want you to contemplate as I'm going through the personas and the story is really, do they reflect real world experiences? Do they provide a compelling reason to leverage and use SDOH data in public health settings? Do they have broad applicability across the public health ecosystem? And are there additional activities or information that are important that we need to include that maybe we haven't? And are they feasible? Now, I also just want to mention that, again, there are many public health agencies and organizations and different types in different settings. We've picked 4 personas, and we couldn't pick personas for every kind of setting. So we know that there are settings that we don't have a persona for, and as we're going through this, think about whether the persona has the applicability. So if the persona is at a county health department, could it also be carried over or true for, let's say, a territory or a tribal nation? So again, we don't have every persona. We had to limit it, and we have only 3 use cases. But even for the story, think about its applicability to other, perhaps SDOH needs and or other chronic diseases. So next slide. Okay, so as I said, we created 4 personas. We have Kevin, Claudia, Victor, and Michaela, and I'm going to go through each one. Next slide. So Kevin is a care coordinator at a federally qualified health center. We gave the community health center the name of Sunville. He's 48. He's a licensed clinical social worker. Happens to be a single parent, and he really enjoys engaging with his patients, really to help them identify and address their health and social needs. The challenges he finds in his job is that he's unable really to maintain increasing the care coordination and addressing the needs for his patients because there's a rising number of patients with food insecurity and other economic hardships, particularly in light of the COVID-19 pandemic, and there are limited resources. And he really struggles in his job to try to find the right resources that provide the needed services for his patients that have been identified through screening for SDOH, and then the data is collected in the Federally Qualified Health Center's EHR system. And his goal really is to try to help his patients identify the needed health and social services to improve their lives, and to also use data in the EHR to better manage, track, and report on patient outcomes. So that's Kevin from the Federally Qualified Health Center, and he's the care coordinator. Next slide. We then have Claudia, and Claudia is a senior public health analyst. She's 29. She has a bachelor's degree in public health and a master's in data analytics because she really loves analytics. She works at a county health department, which we've named Forest County Health Department. And she really loves analyzing data and identifying trends, engaging with the stakeholders to really understand what are her community needs and how can she help that drive and strategize on solutions to improve the health of the community. The challenges she finds in her job is that there's lack of consistent and timely data, particularly related to social care. And that makes it really hard for her to think about what and evaluate the community needs, and then to really help drive and deploy and implement evidence-based interventions. And her goals really are to identify trends in population health to improve the health of the individuals in her community. And she is especially interested in diabetes care because of the impact that it has had on several members of her family. So she has also a personal vested interest in this particular area. So that's Claudia from a county health department. Next slide. Then we have Victor, and he is a public health program director at a state health department diabetes program, and the Federally Qualified Health Center and the county health department are in Victor's state. Victor really enjoys working in partnership and building those with stakeholders across the healthcare system in his state. He really is interested in learning about innovative solutions to the challenging problems around health and healthcare needs. And importantly, he really believes in not letting the perfect be the enemy of the good. And he tries to operate and manage in that regard. The challenges he sees in his job is that his department is quite short-staffed, and as everyone has experienced, the leadership, and appropriately so, has been heavily focused on the pandemic response. And the data he is able to review and get is limited in helping him identify what community resources are needed and available or required to address the state's growing social needs. His goals in his job is that he really wants to help to advance and deploy, again, evidence-based public health interventions that really address health disparities and especially focus on those at risk for or managing their diabetes. Next slide. And last, we have Michaela. She is 38. She has a master's in public administration, and she actually works at CDC in the Division of Diabetes Translation. She loves to work with her grantees on implementing public health programs across the United States, and really understands and recognizes and values the importance of establishing performance and outcome measures to achieve goals. And she is, the challenges in her job is that because CDC gives diabetes prevention grants out to states, and then the states sometimes have a variety of different local organizations implement programs. CDC also gives directly to some local organizations. So there's a lot of diversity in what the grantees at the state level and at the local grantees, how they implement their programs. And so it makes it hard for apples to apples comparisons. And there's not always consistent data across the awardees to help guide program decisions and to identify best practices. And so Michaela's goals are really to help her, to have her help her awardees be successful, disseminate best practices. She really likes to facilitate and wants to, and her goal is to facilitate meaningful peer-to-peer connections and really help reduce disparities, again, among those at risk for or diagnosed with diabetes. So those are the personas. Again, next slide, please. All right, so just to remind you, I'm going to stop here. We're going to have a discussion about these personas, and just remember, if you can, to raise your hand or put comments in the chat, and then we can, go from there. So next slide, please. So these are the questions that, again, we wanted to get feedback on. Are these personas, do they reflect real world experiences of individuals? For those of you on the call that are at state health departments or county health departments or territories or tribal nations, does this seem realistic? Are there additional activities, information, or challenges that are relevant that we didn't consider with regard to these personas? And is there broad applicability to the public health ecosystem? So again, we picked 4, a federally qualified, Kevin at the Federally Qualified Health Center, Claudia at the county level, Victor at the state level, and Michaela at CDC. But they could be applied, those same roles could be applied in other public health agencies. And so that's what we're looking for feedback on. So I'm going to stop there and see who would be willing to jump in and chime in. And I see we have a hand up. So thank you, Alyssa.
Sure. Thank you so much, Amy. So interesting. And of course, I do think that it's representative of public health agencies. I represent a community-based organization that's very data focused. And I wondered, would it be possible to incorporate the perspective of service providers who are doing public health services, as we sort of in some ways conflate social determinants and public health a little bit, because we're using some of the data sets that those 4 personas may also use in our delivery of services. So just a note, that might be outside of what we're considering right now because you're focused on public health as it's traditionally understood, but I just wanted to offer that for comment and discussion.
Yeah, no, thank you very much. So, when we get to the story, clinical and community providers do come into the story a little bit more. They're not just necessarily a key persona, but do really appreciate the perspective. And, we can think about other ways to elaborate on that. Okay, so I see a whole bunch of hands going up, which is wonderful. So I think next I think Julia, you were next. So.
Yeah, so I think part of my question was more clarifying because I think, if the goal of the personas is to be comprehensive of stakeholders, then I actually myself was going to suggest a CBO stakeholder, but I think there are also some, other folks who would be relevant, such as, the CIEs or the service referral agencies, as well as the EHR vendors. So since those folks play a central role in converting and sending data to and from the organizations that you've already mentioned.
Yeah, so thank you. Again, we could, there are endless number of stakeholders, and all the ones you mentioned are incredibly relevant and important. And again, the use cases are really going to be focusing on the public health uses. So we chose more sort of, for lack of a better term, several traditional public health agencies. It doesn't mean that the other players aren't critical and important, and they may come out a little bit more in the story when we get to the story. So I appreciate that. And, as we get into the story and the use cases, there may be a few more, maybe we can add a few more actors in there.
Amy,
So
I
that-
can, yeah, actually the system actors, these are, so when we think of the use cases, they will have the people actors, they will have the organization actors, and they will have system actors, right? So we only create personas for the people actors, but Julia, to your question, we'll definitely have an EHR system actor, an HIE system actor, a public health aid system actor. So they'll be represented that way in the use case diagrams.
Thank you, Evelyn. Appreciate that. Okay, I think Lori, you might be next.
Yeah, I was thinking from my perspective, having received grant funding for some of these purposes, or for the funders like the CDC or the state director that you had as personas, it was implicit in what you had, but there could be more of an emphasis on accountability to funding, you know, or impact. Often we're having to demonstrate impact, and these data could be a part of that.
Thank you. Really appreciate the comment, and we might come back to that. So when we go through the story, think about whether that's built into the story a little bit more. Because again, these are like the characters of the story, and we're just getting feedback on the characters, and then we're going to go to the story. So, you know, let us know then if you know, we can look at that. And as I go through the story, think about if there's enough in there, if there are places that are important to build it in a little bit more. Okay. I don't know whose hand was up first, so I'll jump to Jean and then we'll go to Gia.
Thanks, Amy. I think it's not a good reflection of territories, the state example, and I'm with the National Association of Chronic Disease Directors. We've got state and territorial members, and I think it's a little bit too different to consider that it does represent that. I'm not saying that we need to add a new use case, but I think we just need to be careful about what we're asking that use case to speak to. I think to the trying to carry it over to tribal organizations is also going to be a little hard. And maybe that's something that can actually be addressed in a story, because there are lots of ways tribes and the personas that you have interact. So that might be covered through stories.
Okay, so just to clarify a little bit, let's just take the territories for a minute. Are you saying that the territories, the structure in the territories is different than, let's say, counties and states and federal, so that when we think about that, they may be more like at the state level without the health centers and the county level, or just the way in which they're structured is very different, and none of this would really be that applicable?
Yeah, the way they're structured is very different. And I'm thinking particularly of the Pacific territories. I think Puerto Rico fits a little bit better into the state example, and even USVI. But in the Pacific, there's such a wide range of how they're organized, how they relate to the community-based organizations, and how they relate to the health center. Some of them are the health center. So it's just very different.
I know I don't have my hand up. This is from Shekinah, but in speaking in relation to the territories, the USVI and for Puerto Rico, because we do a lot of work with Puerto Rico as well. We do have the federally qualified health centers, several linkages on St. Croix, one on St. Thomas. And so, and our federal grant structures is very similar to that of the mainland. So there is really not that much difference. We do act as both the state as well as the local authority for the Department of Health. So that structure is not like many states, but similar to some of the smaller states on the mainland as well. So there is some comparison, slight differences, but still some comparison.
Okay,
Thank
great.
you.
Thank you. Gia, you've had your hand up.
Hi. So my first comment is on the first use case scenario for the care coordinator. I think clarifying his goal is to better screen for SDOH needs, identify SDOH resources, programs, and our services, refer a patient to the needed health or social services, track referrals, and monitor outcomes. That's very different from managing, tracking, and reporting. Those terms are more like surveillance terms, which a care coordinator wouldn't be responsible for. So I think considering the use and goal for his role and how we use and track that data around screening, referring, and monitoring the outcomes of the referral. Those are data points that we don't have access to, that we need access to now. I think another gap, is actually doing a use case scenario or even a story from the patient perspective. Understanding that patient's pathway through these services will help you have a better understanding of where those gaps are and the people that that person is going to touch. It goes back to the comment of the community-based organization gap. If we don't have that community-based organization that's on the other end of the referral in the system, we can't monitor whether or not that referral happened and the outcome of that referral. So how do we ensure that there's this bidirectional piece? We're going to have a community stakeholder on the other end who's given that resource.
Yes, so thank you so much for that comment. You know, I will say, and Evelyn or Sheila or Kate can pipe in here, the story, when we get to that, the story is not really focused, and the use cases are not focused on the bidirectional exchange for identification of needs and referral for services. That's not to say it's not a critically important part and it fits into the system, but the story is really thinking about, and we'll come to this in a minute, I'm jumping ahead a little bit, really how to take individual level data around SDOH data around social needs and social risks, and use that and aggregate it up for public health purposes in a number of different ways. Now, granted, part of that is looking at, is that referral in place? Are people getting the services they need? So I understand that, but I do just want to say that the story is, and the project and the use cases are not focused on the bidirectional exchange of referrals, more about how public health will use the data that's identified through the screening and making sure that the services are there. And obviously then the referral information could be relevant. So I understand what you're saying. And I just did want to sort of, I guess, level set in terms of the types of use cases that, and the story that we'll be talking about that will come from the use cases that will come from the story.
And Amy, I'll just add that is exactly use case 1 and use case 2 under the Gravity package. I think it's already in the chat. Those are already spelled out there. So that work's been completed through the Gravity project. And as Amy said, this is really the third use case within Gravity, is what happens after that. So this couldn't intentionally be a 4th use case under Gravity, but we're calling it because it's very public health focused.
Okay, Shay.
Yeah, thanks everyone. First, let me acknowledge fantastic progress. Yay! To the point that Julia and in the chat Ray added, I would say that it may come out in the stories, but tribes are so unique, right? Very unique. It's so different than a county, a state, a community health center, or an FQHC. So a tribe could have a clinic, and there might also be an Indian Health Service hospital maybe on the other side of the reservation. So, there's transportation, there's data sharing issues, there's even, and again, like you said about that bidirectional information, whether the referral actually happened, how does the other clinic get the information back, all of that. And it may come out in the stories. But I do think that these have broad applicability to public health ecosystems with, again, the caveat that tribes are so unique, right? Very unique. So I'll just leave it at that, but I did want to give a big shout out. Woo, progress, and appreciate everyone's work on this. Thanks so much. Over.
Thanks, Shay. Really appreciate your comments and the acknowledgement that, you know, things are so different with the tribal communities, and that does not fit into the story right now. So, you know, there may be some additional work that can be done on that at some point in time. And we recognize that. So, you know, that's why we were calling it out before. But, and the fact that they're, you know, we're trying, so the broad applicability in that case, you know, it doesn't necessarily would apply then to the tribal community. Commissioner Justa?
Thank you. Just so you know, it's pronounced Justa.
Oh,
you can
Justa,
also,
I'm sorry.
yeah, that's okay. You can also call me Tita. But I wanted to kind of go back into the conversation because I just wanted to know in the feedback that we're giving today, how is that actually going to be incorporated in any changes that's going to come about with the last statement that was made? Because I know you got a lot of work has been put into this, and you know, like the conversation was, yes, there's a lot of progress, but information coming from us, how are you actually going to incorporate the changes seen based on our experiences and our culture, and so that we can ensure that there's equity and we are actually touching everyone that we need to touch from a global perspective?
I'll answer, and then if Evelyn or Sheethal or Kate or the rest of the team want to pipe in here. So when we get everyone's feedback and input, both on their personas and the story, we'll, you know, sit back down and look at, you know, what we might need to change to be more reflective overall, and include, you know, and try to build as much as we can within the limits of the project. But Evelyn, do you have anything else that you'd like to add to that?
If I don't know if Commissioner Justa, you mean the actual change that will have, if I'm interpreting for you saying, will this come to actual change in our system and our process?
Yes.
Oh,
yes.
I'm sorry. I thought you meant the actual stories and use cases. I misunderstood. Sorry.
Yeah, no. So we say this at the front, like this is really, we are a project team. We're going to put together a use case package for our CDC team, the Division for Chronic Diseases. And it's for them, you know, it's sort of the next step from it, right? So this really creates, like I always say, these are the baseline of work. There still needs to be more work. It's out of scope for us to inform policy programs and implementation, but we hope this will be used to inform future changes at the system level.
Thank you. And a follow up to that, and bear with me as we go, because I think pulling and tugging sometimes helps a little bit, at least for me to understand, because we've been having discussion, for example, tribal, the differences between the Pacific territories, the Atlantic territories, and how we differ. But I want to make sure that when we reflect because the term is being used that we may make changes. But if we don't include the other areas, the tribal areas, then we're not being inclusive. And so if we're supposed to be looking at it from a whole, then that's why it just a confirmatory is really what I'm looking for. And really and truly, this is just a discussion. I always believe, and I encourage my staff to do the same thing if you can have the discussion. So please bear with me as I put this on the table as a discussion.
Thank you so much. Yeah, I agree. This is really important, and these are all documented, and we have our all the CDC project team here. So absolutely will be taken into account and documented. Thank you.
Appreciate that. Thank you.
Yeah, and the one other thing I want to say to that is there will be a final report from this whole project. So if things don't make it into the use cases, but they're important for recommendations from a final report perspective, we have the opportunity to include it there.
Thanks,
So
Amy.
I do want to move ahead to the story. Thank you for all of your feedback. I want to make sure we get through the story because I'm sure there will be lots of discussion for the story. So again, what I want to do is just go through really a high level story. We've already talked about the personas and the settings. And so like the cliff note of the story, the very high level, which I sort of said before, it's really around individual level data being captured at the clinical or community-based setting, and then being leveraged by all organizational levels and different public health agencies and settings. Next slide. So before I go through the story, just to say, this is actually a condensed, what I'm going to talk about now quickly is sort of a condensed version of the stories. There is a document that will be made available that is a Word document that will have this more in that and a little bit more filled out story. So again, this is a bit condensed, a little bit condensed. So the first part of the story is really into 3 parts to match each one of the use cases. The first part of the story is really around community concerns regarding food insecurity. So this first sort of think of it as a chapter 1, Kevin, who's our care coordinator at the Federally Qualified Health Center, attends a public and environmental health advisory board meeting for the Sunville County Health Department, which is where Claudia works. And Claudia also is in attendance. Remember, she is our public health analyst at the County Health Department. And at the meeting, Kevin raises concerns about the fact that he's been seeing this increasing number of patients with food insecurity, and he's concerned about the impact that this is going to have, particularly on his patients that have diabetes. Since Claudia is about to do a countywide community health assessment, and she heard this issue, she wants to explore the problem more. So she then starts to determine and investigates and where she can get some data. And she learns that the federally qualified health centers and some other clinical and community providers in her county screen their patients for social risks and needs and documents it in their EHR. And she also learns that most of the clinical providers and FQHCs in the county participate in a regional health information exchange, and some of the SDOH data is sent to the Health Information Exchange, the regional HIE. The HIE, and then Claudia works with the HIE so that they can provide her team with their data, some of the social and clinical needs data on the individuals in the county. And then Claudia and her team, when they get the data, they start to analyze the prevalence of food insecurity among people with diabetes in their county. And they want to sort of examine what interventions have already been put in place at a zip code level to address this issue. So that's the first part. That's chapter 1. Next slide. The second chapter is really about the state and renewing its diabetes prevention program cooperative agreement application to get more funding from CDC, to get continued funding. So Victor, remember, he's the diabetes prevention program director at the State Department of Health. He's working on a renewal application to CDC for continued funding. As part of the application, he too is conducting an assessment across the state of local programs that the money he got from CDC funded. So the programs that his program is funding in the state, along with any other diabetes prevention programs in the state that might have been funded directly by CDC. So he's looking, what are all the diabetes prevention programs in the state, both some that he's funded with the CDC grant cooperative agreement money, as well as other programs that may have been funded directly by CDC. He's specifically interested in learning more about diabetes prevalence and the level of food insecurity at the zip code level since these programs were implemented. And he also, again, learns that there is SDOH data in the regional HIE, but that's only part of the state. So that he also realizes and learns that he can get access directly from some clinical and community providers that are not part of the HIE. And he also learns that there's some Medicaid claims data, there's Z codes in there. And so he determines that he can combine this data with his program data to better understand how the programs are performing on an ongoing basis related to diabetes and food insecurity. And because he really believes that, don't let the perfect get in the way of the possible. He knows that the data is not perfect. It doesn't cover everybody in his state, but it does seem to be the most robust and standardized and timely SDOH data that he can gather in time to use in his renewal application and potentially use on an ongoing basis. So that's the second part. That's chapter 2. Chapter 3, or the third part of the story, next slide, is now we're working with Michaela. She remembers the project officer at the CDC Division of Diabetes Translation, and she has Victor's state. She's a project officer for his state. And Victor and Michaela have become close colleagues as they've been working together over the years on the program. And Victor shares with Michaela that, the findings that he was able to analyze and how he was able to leverage clinical, community, and claims data to get a better understanding of food insecurity among people with diabetes in his state. And he's excited about the ability to do this, and it was put in his renewal application. So Michaela wants to ensure that all the DPP awardees are leveraging data to better assess and monitor their programs for the grant or the cooperative agreement, especially related to addressing SDOH. And she encourages all the awardees to track and report the number of individuals with diabetes by race and ethnicity who have been identified with food insecurity as a social risk. And she's encouraging all of the awardees to then set a target to reduce that number. And that is actually based on some recent SDOH measure guidance from CDC. Additionally, CDC wants to try to ensure that all awardees are leveraging US CDI version 2 where applicable, and that they are utilizing standards via the Gravity Project in their program monitoring efforts. So that is part 3. So each one of those stories, the first one again around the FQHC and the County Health Department, Claudia, and working together with Kevin to get data so that she can do the community health assessment for her county. And then we've got the second part, which is Victor, who's also going to leverage an HIE and some of the same data sources as Claudia to try to put into the application, the renewal application for the diabetes prevention program dollars. And then the third part of the story is, again, CDC's project officer working with the states to encourage this work in a broader way across all grantees. So next slide. Again, please feel free to raise your hand. Next slide. And we're going to go back to the same questions and open it for discussions. So as I shared this story, did it resonate? Does it reflect real world experiences at the county or state or CDC level? Granted, understanding that territories and tribal nations are somewhat unique and different, and it may not totally apply. Does it provide a compelling reason to leverage the data and use SDOH data for public health purposes? Does it have broad applicability? Is it feasible? What are your thoughts, comments, suggestions, additions, changes?
Amy, I'm going to go back to each story, so maybe we can do it by slide. Does that work?
Great. Yeah, absolutely.
Thank you.
Okay, so for part 1 or chapter 1, talking about, collecting data from an FQHC and then working with that at a county level. Lisa, you have your hand raised. You're on, you need to unmute yourself. Thank you.
Thank you. Sorry about that. When you mentioned the HIE having this data, I just wanted to clarify that even though I guess they're going to be getting the information from the individual providers, they're not actually getting the information from the HIE, because you actually sort of have to have some type of relationship with the HIE, either as a participant. You can't just go to an HIE and ask for data. So I guess we just need to make sure we're clarifying how the HIE fits into this puzzle in terms of how do you get that data.
So I think in this part of the story, what we were trying to convey was that if that sometimes there's a data intermediary, like an HIE, that might be getting data from the clinical and community providers, and it may be a resource for getting data for, with clinical and SDOH needs if the HIE has it. So I'm trying to address your questions.
Amy, I think for Dr. Lucas, there's kind of assumptions baked into the story as we write it. And so, yeah, definitely there has to be a partnership with the HIE, and that would be kind of one of the preconditions we would list out as we're going into the use case package, if that helps clarify.
It does, thank you.
Yes, thank you, Sheetal. Okay,
Also got a comment. If it's okay, I can read it out loud. Lori, thank you so much. She mentions that I appreciate how the story chapter shows the value of food insecurity data from the local to national level. Thank you for the comment.
Other questions, comments? Is this realistic? All right. Anyone here from?
Yeah, this is Ray King. I have a comment. Sorry, I could find the raise your hand. But going back to the CBO example, I mean, I think the use cases and the personas do a good job. And I'm biased. I'm one of the leads for the Cody project. But I think it describes the traditional way of CDC doing, and I'm in the chronic center, of doing public health, where we expect everyone to just give local public health, state public health, and federal, national public health their data, clinical and community partners, so that we can look at social determinants of health. And I don't think that's realistic. And I think if we just make that an assumption without putting CBOs as one of the personas, or, you know, and this is I have no knowledge or understanding of tribal, so I'm putting that aside. But I think it fails to recognize, and then really spelling it out in the story. And I see this across chronic as I talk about Cody, where there's expectation that data is just going to come to us. And I think that has to be part of our use case or user story, or we're going to have, I mean, I recognize in our language within chronic, everything in those stories that we want. But if we don't address how we get it, I think we still, at the end of the day, end up without access to the data, because the clinical and community partners that have that data aren't part of this user story or the personas. Because I think if there's not a value add for them, I don't think we have, you know, unless we're just purchasing the data outright. I think it neglects them. And also, I think they have an equal role. It's not just the government organizations that are doing public health, it's all these other partners. And I think, you know, COVID has really shown that, and how we include those in the way we think of the public health ecosystem. And I know that's not your job to address that writ large, but maybe the other chronic leadership on the call can help us think about that and how we address that in our development of our systems and information exchange.
Thank you. Great comment.
Yeah.
I see, Dorella, you have your hand up.
Hi, yes, thank you so much. I think bullet point, following up with what we just heard, I think bullet point number 4, in terms of the F2HC's screening for social risks and needs, I think what we discovered is that it's often not clear what information is being gathered. And sometimes there are facilities that aren't even looking at screening for food insecurity at all. So I think maybe you just want to like allude to that in the sense of the moment of discovery, and perhaps creating an opportunity for everyone to uniformly ask the same types of questions, so that any data gathered like in the future is in line, right? Because if some orgs are not asking at all or screening at all, then it puts a flaw into your whole process, if that makes sense.
So if I hear you correctly, you're suggesting, you're addressing the fact that we need to standardize not just the response to the questions, but actually standardize the questions.
Yes.
So we can be asking the same questions, and then that will help standardize the answers for data sharing for the answers, correct?
Exactly, yes.
Okay.
Thank you.
Rashid?
Hi. So I wanted to briefly talk about the level of geography that we measure these data sets in, you know, for example, food insecurity. What I've observed based on my experience over the last couple of years is it often becomes too big of an area to measure food insecurity over, you know, when you're, you know, measuring over entire counties. And then you're looking at, okay, what programs are being employed in specific zip codes or at a lower level. It often becomes too big of an area because you might have a lot of variations within one specific county. But when we aggregate that data to that level, the county might look okay on the surface level, but there are a lot of these areas which really need a lot of social support, and we kind of tend to miss those.
Okay, so just to be clear again, are you saying that when you look, some of the story talks about looking at things at the zip code level, but then you're saying when you roll it up to the county, it might get diluted?
Yeah, basically.
Okay, so so that's just
And
something
then
we
there's
can keep.
also the variability between like different data sets. Food might be one example, but when you're looking at food, and then you also want to look at something like income, which you can even get at a census tract level, there's just a lot of variability, and comparing apples to apples kind of becomes hard at that point.
Great, thank you. And I do want to just go back to something that Evelyn put in chat and mentioned, which is with regard to the comment on screeners, that really the Gravity program, the standards developed through Gravity really structure the data capture at the individual level to be aggregated and used. So Evelyn, did you want to pipe into that?
Yeah, I was just also in our business case. So again, we know that there's, as noted, there's different data sources. So absolutely, you have individual level data, you have, zip code data, income data that can be, captured at different areas. And really, as we've seen in our business case, this is one data source, right? So EHRs are one of many data sources. So our use cases are really, the story here is really how can we better use that data, knowing that it will need to be combined with other data sources. But our scope is to say, if you have data already being captured, and with, we talk about the Gravity standards here that you have now, and then again, the Gravity project identifies the standards, but they're national standards, right? So they're going through, they're in USCDI V2 now, they're published by the coding steward. So they're made available for the country at large. So I think this is really to say, if you already have a means to collect structured data, how do you use it, right? How can, for chapter 1 here, how can the federally qualified health center better use that data for the public health purpose?
Thank you. So we're going to take 2 more questions on this because I see 2 hands raised, and then we're going to move on to the second part. So Jen, I think you had your hand raised, and then we'll go to Gia.
Yeah, I just wanted to point out that, having an HIE that can combine that SDOH and clinical data is definitely something that a lot of areas are working towards but don't have. So for like in our area, we can get the SDOH data, but we don't have it linked to clinical data yet. So I just want, in terms of how realistic this is, I just wanted to mention it's not realistic in our area yet, nor I think in quite a few others.
Great, thank you. And we can address that either as an assumption or change it a little bit, or say, if this were the case, then that. So appreciate the comment. All right, Gia.
So I believe my comments for the story part 2. So
okay, perfect. Then let's go on to.
Yep.
Perfect. That's exactly where we were going. So jump right in here.
So I think in this section, we might need to do a little more editing and digging in, because it goes back and forth between talking about the DPP and services for people with diabetes. So people with DPP with diabetes already are not eligible for the National DPP program. So we just need to make sure, and we'll work with you to tighten up the accuracy of how it's described in the services that they would discuss and the outcomes we want to look at. Because essentially we wouldn't want to look at people's diabetes outcomes, because folks in this program have pre-diabetes. So I can do track changes in the document and tighten this up and share with the program branch as well, because discussing about the funding piece is also an issue, because right now we're writing funding packages. So I think that there might be some, discussion that our program branch might have some comments about that too. So
great, thank you.
Comments and track change.
Yeah, no, absolutely welcome your input and changes if we don't have something correct here, and happy to work with you offline to correct that. And we didn't know you were working on your funding packages right now when we put this out, so we don't want to create challenges for you on that front. Okay, so other comments. So again, other thoughts, given the fact that this might need to be tightened up a little bit in terms of the language and the specificity from a more general perspective. Any comments or thoughts on this story? On this part of the story, rather.
We have a comment in the chat. Thank you, Dr. Lisa. It says, I have been working on the Gravity project and the standardized screening and codes will be very impactful. However, I anticipate it will take significant time for the adherence to using those standard screening tools and incorporating them into the EMRs and codes. But hopefully in terms of USCDI version 3, inclusion of SDOH categories. And yes, thank you, Evelyn, for jumping in. That is absolutely, we are diligently working with our federal partners to support the inclusion of the standardized codes to support an interoperable environment. We appreciate and we want to hear from you as well. If you are testing and implementing the SDOH coded terminology, please feel free to bring any input as well. Thank you.
All right, other thoughts on this? Nancy Sutton, if you're here, I think I saw you earlier unless you had to drop. I know you work at a state health department. Do you in chronic disease? Do you have any? I'm trying to see if Nancy's still on. No, maybe we lost Nancy. Okay. Anyone else from a state health department here that, or a state that may want to weigh in on this? Or worked with the state? Fran, any thoughts on this one?
Nope. I mean, I disagree with the NDPP issue.
Okay.
I'm not part of the health department, so.
Yeah. Right, I know,
I know you know.
Didn't know if you had perspectives from previous. All right.
Thanks.
Hi, thank you. We have 2 comments in the chat, Amy. Just wanted to highlight those.
Yeah.
From Jennifer. I think an important part of the story is that is only lightly addressed in the amount of missing data and why it is missing. If you are advocating for continued funding and needs and applying that approach more broadly, you cannot make the assumption that missing data means that there's no need. It feels unrealistic to me from that approach. And then we also have another comment. And please,
so wait, Gabby, for a minute. Jennifer, can you elaborate on that a little bit more? Would you be willing to do that?
Hi, yeah, sure. I think, we receive a lot of data from partners, and like SDOH data is fairly lightly collected. I recognize that the story does kind of touch on that like certain partners will collect certain information. You might use some Z codes, you might use these different kinds of sources, but like we're talking about less than 10% in what we're receiving. And so to say that like, just because I don't have information about somebody's food insecurity means that they're not food insecure, that would be a false assumption and a like gross assumption. It would be really inappropriate to make that assumption. So especially if we're talking about different regions, I don't know, just when you got into that part of the story where I think it's part 3 though, but talking about how Michaela wanted to apply this and encourage all the awardees to leverage their data this way, they just may not have any access to that kind of data to do that. So I just wanted to call that out.
Right. Thank you. And, again, we recognize that the SDOH data is not being consistently collected in a lot of places. And if it is, it's not all, aligned yet with the gravity standards, and that there's work to be done there. So with the use cases, when we get more into the use cases, we have the opportunities for the preconditions and assumptions to think about, whether we want to include that to say, when we get there, this would be an act, would be an applicable use case, or if we need to modify in some way, shape, or form. So appreciate those comments.
I have 2 more comments as well from Ruth. She's mentioning, I'm working with 2 health systems on adoption of WellRx. We have been using VSAC code sets, oops, I moved, for health concerns, goals, and interventions. Thank you, Ruth. And if you're able to, we would love for you to chime in a little bit.
Ruth, on that comment, when you talk about health concerns, goals, and interventions, are you also using those code sets? Is there anything there more specific to SDOH needs and social risks?
Yeah. They're using WellRx. There are LOINC codes for the WellRx. So those are stored in addition to, they're working towards, one client has actually mapped the result of the WellRx to one of the codes within the VSAC that the Gravity Project is curating, and they are stewards of, and they have linked that to the goals, and then are looking at trying to chunk the interventions because they're associated with assessment, could be care coordination, could be referrals, et cetera. There's multiple different groupings of those interventions too, because they're very interested in being able to assess the impact of their efforts to close social needs. So what I'm seeing, and it's like, again, I come from like a health services research background and public health. So I've worked both ends of this, and I do think it's a matter of time. And the more the vendor, the EHR suppliers can get that data actionable at the point of care, I think that's where we will see the uptick in the use of the codes. Because again, it's one thing to do the screen, but you also want to have a sense of what was effective in closing the social need.
Great. Thank you so much for elaborating on that. Julia, I see your hand up, and I know you've put a couple of comments in chat. So
sure. So yeah, and I just want to clarify my comment, which was not about interventions, but rather about goals. I'm not against structured data to describe goals, but the intent of the care plan DAM or domain analysis model was for goals to be really a more patient-centered concept where the patient says exactly what they want. I think actually SDOH is a pretty useful example for this, because it's easy for someone who's interviewing a patient to say, oh, the patient is homeless, therefore their goal should be some kind of temporary housing. But if you don't ask the patient explicitly what kind of housing is acceptable to them, you could easily go through a process of offering them a service that's not wanted. So I just wanted to call out the importance of having free text and bringing the patient's voice into goals. And I would also say furthermore, and no disrespect to the comments for USCGI from Gravity, that I don't fundamentally see a need for SDOH goals to be different from goals in general, because I think of the care plan as a flexible tool that supports any kind of health concern or need, regardless of whether or not we put it into a medical category or an SDOH category or something totally different.
Thank you. Okay. Let's see. I don't see any more specific comments. There is a comment about some HIEs do support Sync Health as one SDOH data. Okay. I do want to get to, well, we are on part 3 here. So any additional comments on part 3? Or at this point, anything specific to part 3 or any of the parts? Any more thoughts, comments?
This is kind of seeing I'm driving, so I can't put my hand up, but I just wanted to say that I think that things are flexible enough that can be applicable to a wide range. So besides that, I have no comments.
Thank you. Okay. All right. Just quickly looking through chat as well. Make sure we didn't miss anything. Okay, so last call for comments or thoughts. Again, the story is sort of the basis, the part 1, part 2, and 3 sort of will, each part will lead to a use case where, you know, many more details will be added, and, you know, the outline for the use case package that Evelyn showed earlier will be developed for each one of these components of the stories. And as I said, we'll go back and take the comments and thoughts and, you know, determine if there are adjustments that make sense to be made as we go ahead and start to build the use cases.
Wonderful.
Okay, Sheethal, Kate, Evelyn, anything else you'd like to add or ask the group?
None
No.
from my perspective.
Yeah, I was just gonna remind everyone too that this is the first time we're presenting, and so our process is, just from a process perspective, we're giving you a snapshot of the patient story, and in the coming weeks as we go through the, you know, we'll be doing a deeper dive. And so we do need your input. So it was fantastic feedback today. So this is exactly what we wanted. But as we move forward, we'll also be asking you to, you know, continue giving us feedback through this process. And then we'll have an end-to-end review of the patient story and the use cases before we go to consensus. So we have lots of opportunity to refine this along the way, but today's feedback was excellent. We hope to continue that with future discussions.
Thank you. Okay. Thanks, everyone. Again, really appreciate the comments and the lively discussion and input and feedback, as Evelyn said. Thank you. So I'm going to turn this back to Gabby, I believe.
Yes, thank you, Amy, so much. Fantastic job facilitating that very lively discussion. We appreciate everyone's feedback. We're going to turn a little over now into our next agenda item and review Confluence and homework, next steps and homework with all of you. So please, thank you all for staying in with us. As you may recall, we did ask you all to please provide a vote on the public health business case to achieve consensus. We're happy to share that we have reached consensus. 63% of committee members voted. So we are extremely grateful for your engagement, your participation, and of course, helping us move forward this deliverable to a final stage. So we are extremely, extremely appreciative. To give you a sense of the breakdown, so you had 4 options as committee members voted. You had yes or yes with comment. You also had the option to object and to either abstain, or if the Survey Monkey form was not completed or was left blank, then that will also count as blank. So here is a breakdown. You know, out of this, so in total, we have 184 work group members. As of Monday, when the consensus vote closed, we had 84 committee members. Out of those, 53 submitted a vote, and that's how we got this analytics here to present to you. So everyone who voted, really I think it was across the board agreement on the need and the why for this initiative. So again, just really this is a team achievement and a great milestone. To give you a sense of our committee members, who we have in the room. This is a public call, a public collaborative, housed within the Gravity Project. So we have committee members defined by partner type. Again, as mentioned, 84, 53 of them voted. We have representation from public health agencies, federal, state, local agencies. An example here are CDC colleagues. We have other, whether that is research or any of the options that are not displayed here. So again, this is a cross-sector collaborative. So wanted just to highlight who we have in the room and where we got those votes from. And for those that submitted, for the votes that were submitted, yes, with comment. So in total, 7 workgroup members submitted comments during the voting period. Feedback has been successfully integrated into the final deliverable, and dispositions will go out this week. We want to ensure that everyone will receive a response to their comments, so we can get your stamp of approval and move forward with publication. Some general themes included tech language edits. We did have some description on the Gravity project description adjustment that was accommodated, as well as some relevant updates and resources that we should keep in mind in terms of initiatives that are data initiatives that are relevant to our work. Just to share with you, our deliverables page is available on the Confluence site that we have. It will be labeled as CDC, Social Determinants of Health, Public Health Business Case Final Deliverable, and it will be posted on Confluence as we are, within the coming week. So again, very grateful for your support. We have successfully achieved this deliverable. I'm going to pause here and see if there are any questions or anyone would like to share any feedback on the business case. And I see there are some other engagement in the chat, which we of course appreciate.
Gabriella, this is Shay. I just wanted to say that while it's either the personas or the case stories, etc., that I understand that tribes are very unique and complex, particularly even in terms of social determinants of health and health access systems, as well as the data collection. And it is not lost on me that we could do a whole focus area just on tribes. But I do appreciate the team's reactions for inclusion as much as possible of the unique perspectives and systems that are serving our tribal nations. Now, of course, we know that the US government has a special trust responsibility for tribes. It's in the Constitution. The US government does not have a special trust responsibility for local health departments, states, or territories, although those are very important pieces. And so again, I just want to see how, or bring again, how we can be inclusive of that convoluted and complex tribal world without derailing, if you will, all of these other works, because they fit together, but it's just so unique. So I just wanted to point that out and say thanks again. Over.
Thank you, Seth. We appreciate the awareness on bringing forward such an important topic and ensuring that it's part of that discussion. We know that that is something that on the project team end, we have discussed it. We are aware of the limitations as well as the constraints as associated, as you mentioned. So I think bringing light to the issue, it's definitely important, and thank you for sharing. I'm not sure if we have anyone else from CDC that would like to jump in on that, but I think we are aware and we are trying to work with you and trying to work with each other on how we can best incorporate the uniqueness of our tribal communities. Appreciate your feedback. Now, without further ado, we would like to provide a Confluence navigation. Some of you, this might be your first meeting. Some of you are returning members, so we thought it would be good to orient you to the page where all of the meeting information, materials, and resources are posted. So now we'll hand over the virtual mic to my colleague, Savannah.
Hi, everyone. How are you? This is the landing page of our Confluence site that we have shared a couple times in the chat, and I think Gabby's going to share it in the chat again. This has our general background and a scope, a very brief overview of the initiative. If you scroll down a little bit, some of the most important things that you can find on this particular page is the workgroup meeting schedule. Here you can find all of our meetings. Each meeting, it's every other week for 90 minutes. You can find the date here. as well as the topic and agenda that we'll be discussing for that week. And you'll find all of the Zoom information. You can find the Zoom link and put it in your calendar. This page is updated very regularly. We put in the pre-meeting materials as well as the homework. And then within 2 business days of the meeting, we also will post the slides and the recording. Of note, we did just recently post the Cody Cords question and answer document. This is just a reference guide. This encompasses the questions that were asked both during the chat and live during our meeting last session. So we will be posting the slides for this week. And then we'll also be posting the stories and personas from what we discussed from this week for you all to reference as well. If you continue scrolling down, sorry, Gabby, you can also find key contacts. This is Kyla Davis, who's our CDC representative, myself, Savannah, and Gabriella. If you have any questions about either Confluence, about the work group, or just want to provide feedback on, for example, today provide feedback on the stories and personas, or just general feedback on the work group itself, please feel free to email any of us, and we will get back to you, and you'll likely see us CCing the other key contacts in here as well. You can also see definitions at the bottom. These are frequently used definitions or terms that we will refer to during meetings, so it's also a great reference guide. If you scroll back up, you'll also be able to find all of our documents. The easiest way to get to all of our documents is under the project charter. There's a link. You want to click on that for me, Gabby? Thank you. Here you'll find all of our project documents. There's the initiative one-pager, which provides a little bit more in-depth overview of this initiative, as well as the timeline. If you scroll down, the most important things that you'll find on here are our work group deliverables. These include the project charter, which we just took a consensus vote on. So we will be posting the updated project charter shortly once we incorporate all of those comments like Abby mentioned earlier. We will also be posting the public health use case package, and which include the personas and those stories that we talked about once those are finalized as well. If you go back up to the top, there's a link there that will take you back to the home page. The other notable link on this site is to go to the Listserv page. Right under workgroup information, you can click there. You can go to the Listserv page. This is where you will sign up. If you have not signed up already, we invite you to do so either as a committed member or an other interested party. If you have signed up or you can't remember if you've signed up, you can scroll down and you'll see a list of all of the names of people who have signed up. You can search for yourself. That's probably the most important thing. You can either filter by name, or you can click the filter button, filter whole table, and then you can go ahead and type in your name to see if you're actually there. And you can see my membership status. This is also a great way to check your membership status. This is particularly useful when we are doing the voting, as we invite the committed members to vote. If you would like to change from other interested party to a committed member, you can feel free to email Gabriella and she will update that for you. If you do need a reference of just what the difference is between committed members and other interested parties, we do have the definition here as well. And just another little plug, another reminder from that page where you signed up, we will add your name to a listserv. That's the best way for us to contact you, as we have almost 200 members signed up. We did create a listserv email address. So we do invite you to please add that email address to your contact list so it does get filtered out of spam, or contact your IT department if that is an issue. I believe that is it. Do you have any questions for Confluence navigating it? Please feel free to reach out to either myself or Gabrielle.
Thank you, Savannah, for the navigation. I hope that supported some of our new members become familiar with how you can contact us and where you can obtain all of our materials. We'll pause here briefly and see if there are any questions. Hearing none, we'll move right ahead. So as part of a follow-up, so if you were unable to provide feedback during today's call, we had extremely lively session. So we really thank you for all the input. We will share a Word document of the personas and a story, and you can send us recommendations for revisions or additions via email. That will allow us to track changes. So you will receive a Word document so you can, add your comments or revise with track changes. We'll be very happy to receive those via email. As a friendly note, we need to define only a selected number of personas for the public health story and use cases. Our focus is in creating a personas that can help us reflect real life scenarios. So we do have a cap, but based on the feedback, which was majority positive, we definitely need to make some tweaks to it. But this is another opportunity. Please submit your feedback by Wednesday, May 25th. We know there's a holiday coming up, so we want to be mindful of getting that off your plate before the holiday. Some closing remarks. As Savannah mentioned, if you haven't done so, please join our work group either as a committee member or other interested party. You have our access there via the chat. And for any work group information, questions, you have our contact information as well. Any questions, concerns before we wrap up? Hearing none, I'll give you back a few minutes of your time. Please stay tuned for the slide deck as well as the recording will be posted on our homepage, and you will receive a Word document of the drafted personas and story for your offline review. Thank you all for participating and helping us build a national consensus, being part of a national consensus building process. Thank you all.
Thank you, everyone.
Have a great Tuesday afternoon.